Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. All right, welcome everyone to the May 2022 Pre-Hospital Care Research Forum Education Research Journal Club. And we are here today. We're going to be evaluating some of the research that has come out of Australia. I'm Megan Corey. I'm here with Katie O'Connor, and pretty soon Bill Toon will be joining us. We're here with the Pre-Hospital Care Research Forum Journal Club. We want to thank Limmer Education, who has been our sponsor for this journal club. And we're going to bring you something that's really interesting today, which is the Fluency and Confidence Predict Paramedic Diagnostic Intuition, an experimental study of applied dual process theory. Again, this is out of Australia. This is an experimental study that I think you're really going to enjoy. Take a read through this article. This is in the International Emergency Nursing Journal in 2022. Toby Keane is the primary author. You might recognize some of the authors in here. We've actually had, I think, Bill Lord on this webinar before discussing some of his research, and he is a meticulous researcher. So this is a really great study. Take a close read of it because it's got a lot of background and theory in it. So Katie, you're on with us today. Thanks for joining us, and we'll be looking at this kind of closely. I wanted to talk about some background first. So this is a study that looks at dual process theory, and it specifically applied, and that's a decision-making theories or groups of them, specifically applied to the paramedic diagnosis or the paramedic diagnostic process. Right, so we know that the importance of accuracy of the paramedic diagnosis, or whatever we want to call it, impression, is extremely important. On the positive sense, it can result in immediate and high priority or immediate care for high priority patients. That's and streamlined health care after leaving the field and going into the emergency department and onward. And we know that in the opposite side, the negative impact of an inaccurate diagnostic impression made by the paramedics. So one of the things that we also know is that it's unique when we talk about decision making and applying these theories. You know, a lot of these are studied under laboratory conditions or in other fields, but specifically in the field, we're talking about high priority situations under extreme, pressure and under time constraints. So these are the conditions that are specific to our field that we want to make sure that we're looking at. You know what? Before we get into the study, I wanted to bring up two important things. So just the little seeds there of what we're going to be looking at today. But there's two things that we want to look at that are coming up that we want to announce. One is there is an upcoming deadline for a call for abstracts, abstract submissions. If you're out there and you've got some, gobs of data in your program, and you've been thinking about research questions and wanting to put something together, the abstract deadline is a little over a month away. So that's time to actually crunch some data and ask some questions, bring a small team together and submit your abstract. June 30th, 2022, this is the educational, clinical, and systems abstracts are submitted. And this is for presentation at the International Scientific EMS Symposium at the EMS World Expo in October in Orlando, Florida. If you are interested in this, you can go to prehospitalcare.org. You can find out more information about it, and that's actually where you submit your abstract. If you have questions about this, you can email pcrf@mednet.ucla.edu. And this is the abstract submission where, or the presentations where the best clinical research for 2022 receives a cash prize, as has been done in the past, where $500 to the top clinical research, and travel grants of up to $2,000 to present the research at an overseas international conference. So we've had this before. I think Remily Crow may have been the last one. I can't remember who the last one was. But we have even more very exciting news. This one I'm really excited about. So we are doing a special edition of the Pre-Hospital Care Research Forum Education Research webinar. This webinar next Friday, 1 week from today, live from Louisville, Kentucky. That's June 3rd, and this is at noon Eastern time, so a little bit of a different time, noon Eastern time. And this is going to be a special thing coming from AccreditCon. We are going to be, Dave Page and I, and Katie, I think, Katie, you're going to be there, right?
Yes, I'm going to be there.
Awesome, great. So we are going to be doing a lunch and learn. In between the sessions, when there's lunch going on, we're going to be out and about, or at least parked somewhere, essentially, and we're going to be talking about an article that was recently published that gives us a profile of paramedic programs in the United States in 2018. It was published just in February this year, and we're going to talk about that type of research and which, where to go from there. This is a really great descriptive look at the profiles of paramedic programs. So join us. We do have the link. It's been placed in the chat for registration if you want that now. And otherwise it will be sent out as well. You can look for it on the PCRF website. So 2 exciting things. Abstract deadline, June 30th. Join us next Friday for that special edition of this Education Research Journal Club webinar. All right, now back to this. I was getting all excited about this study, and then I forgot that I was supposed to tell you about these 2 important things. It's a good thing I had slides in there for that to remind me. Okay, so this is, again, going back to the study from Australia. We did ask the authors to join us, but it is 3 o'clock in the morning, so I think they kind of like to sleep in Australia. So, but we're going to look at this, the way that they wanted to get at this idea of how do paramedics make this diagnostic decision and determine an impression under pressure and with very little information. In particular, they focused on dispatch information. So when you get, and just a piece of this, because this is really in its infancy, this whole field is really in our area, excuse me, in EMS, is really in its infancy. So how to mimic that. And so the big question here about, what is the process of this decision making? They used dual process theories as a way to kind of undergird or support this research and to pull concepts out of it. And you'll see some terms here that come directly from 2 specific theories that are in dual process. So people might be familiar with the book, and if you read it, congratulations. I have not read it, but I've heard it's very tough to get through, and that's the Thinking Fast and Slow, that talks about these 2 different types of decision makings. And type 1 and type 2 decision making have to do with type 1 is that intuitive, fast, it's reliant on emotions and automatic thinking, whereas type 2 is more deliberate. It tends to be verbal, it's slower, and sometimes people call it more rational thinking. And we know that there's probably, the truth is there's probably a mix of 2, and that both kind of influence the other. And then the authors go on to say, within the many dual process theories, there are 2 that have been applied to clinical decision making. One is called the fast and frugal, and the other is the fuzzy trace. We won't get into the details. Check it out in the background. You can read some of that, but it does go through some of the terms that we're going to use in here. And so what they wanted to do was kind of get at a little bit of that. And they said, because it's so new, this is actually, it's a descriptive study, but it's also kind of an exploratory study as well. So what I've got here is the summary of what they did, and I'm going to go back and forth with how do you get this. If you want to design a study and you want to look at how do paramedics make these decisions within a short period of time to determine an impression based upon dispatch information, how would you get that? And they actually looked at both paramedics and paramedic students. So they designed their study, did a sample size calculation, and then they had a convenience sample of participants. So they invited participants, they got some information, gave them information, invited them to participate, collected some demographics, and the demographics you'll see are gender and years of experience, age, gender, and years of experience. Years of experience when it was a student had to do with which year they were in school, knowing that Australia is a baccalaureate program minimum, so it's a 3-year program, but some of the students can be 4-year if they do a dual degree, and you'll see that. And then the experience for those who are working paramedics was gathered as well, and then those ended up being divided into 2 groups, the less than 13 and more than 13 years of experience. And then what they did was participants completed what are called practice tasks. So I'll show this, a couple of images of this that are in the actual article. But what they did was they wanted, they used a mapping task. So again, it's supposed to mimic you're being dispatched. Now this is an experimental study that's done in a classroom with computers. The paramedics had a kind of a tablet style computer and use their touch screen, and then the students had a desktop, but I think they had also touch screen. And so these are clicks, points and clicks that they're using, not it's not a real, they're not out in the field, it's not simulation based. It's simulation based in the sense that it's a case study in front of them on a screen. So the task that they're going to complete is to practice first is a mapping task. They're going to be given a dispatch, and then they're asked to map points. That you'll see a map and you'll see points on a map. And actually, I'm going to go forward a slide and come back. So this is an example of this mapping task, and the bottom of this image is a map. It looks just like Google Maps or anything else. They would be given okay, you're being dispatched from here to here, and then they had 12 seconds to identify the points where they would use to travel to this location. So they did that a couple times. That was a practice task, and these are timed. So it's actually not timed. It's given flashed up for 12 seconds, and they practiced this on 3 different mapping tasks. Then they added the little bit of dispatch information that you see in the image. It's maybe 3 or 4 lines, 3 lines about what you might get in your average dispatch. Your dispatch to a patient. This one, the example is dispatch to a patient with chest pain radiating to both arms. Pain is similar to a previous heart attack. Patient has coronary artery disease, hypotension, and is vomiting. And that's what you get. So when they do this, they get the information and the mapping. They still have to do the mapping task. The entire thing is up there for 12 seconds. So they practice doing these things. And let me go back to this flow chart. And then they complete this practice task 1 through 3, which is just mapping task only, 3 of them, no questions, no clinical information. Then they do 3 more, which is the mapping task plus the clinical information. Now, following the clinical information, it flashes up for 12 seconds. They read, they do the mapping task. And the reason they do the mapping task is it's designed to promote and trigger intuitive thinking. So this is actually a study that's based on some of their previous work. So that's been shown to stimulate intuitive thinking. Then they get these 3 questions. These 3 questions are related to what their research questions are, and I'm going to put that up in just a second. So the 3 questions are, thinking about that pre-arrival information. What do you think's wrong with the patient? And they get 4 choices. So that's the impression. And the choices are in random order. They're going to be mixed up every time. Acute coronary syndrome, respiratory tract infection, musculoskeletal injury, or pulmonary embolism. They select that. Now, when question 1 comes up, a timer starts between the time they see that and the time they select the impression. So that's measured. Then the next question comes up for that previous question that you chose. Based on the pre-arrival information, how confident are you about your answer? And then that's a Likert kind of scale. And then the last question is based upon that pre-arrival information, how representative or typical was that patient compared to others with that same impression that you chose, that you either know about or you've experienced, and they choose typical, on a scale of, very typical to very atypical. And so that's a Likert. And then they move on to the next one. So now that they do this in the practice sense, and then they do it in 4 experimental tests. And you'll see that these 4 vignettes, clinical vignettes, are actually developed by the research group based upon some past research and based upon developing from real case studies of patients and the epidemiology of disease. They chose acute coronary syndrome as the one that they were going to base this decision on. And each of these vignettes is going to have a condition or a description where it's considered to be most likely to be acute coronary syndrome, or likely, or less likely, or least likely. So this is the entire experiment here. And what they're trying to get at here, and these are the descriptions of what we mean, the most likely to least likely. What they're trying to get at here is, this is the objective versus the paramedics' subjective determination of their confidence, and whether or not this is typical, whether typicality they call it, of the diagnosis that they chose in the first question. So these are the 4 vignettes. So you would see a mapping program, and then one of these vignettes would come up. So the most likely, and again, you'll see the likelihood was demonstrated in the previous study, and the stimulus that the participant gets is, you're dispatched to a patient with chest pain, radiating to both arms, pain similar to a previous heart attack. Patient has coronary artery disease, hypotension, vomiting, and then there's likely, and you have something that's a little, less obvious, less likely. I do have some questions about some of these descriptions, and I know, Katie, you probably do too. And then least likely, something that has, and each one of these has cues, although the cues are italicized here, and that's what they say in the bottom in the note. They're italicized for us as the reader, but not for the person, the participant taking this little experimental test. So they don't see the cues for, what the person's basing their decisions on is shown here. So this is the static part of it. This is the objective likelihood. And then the participant is reading this, doing the mapping exercise, and answering those 3 questions, which are, subjective, selecting their impression, determining their confidence, and then saying whether or not the description they thought was typical of the disease that they picked, the impression that they picked. So the participant characteristics were, you had a total of 108 participants. 64 were paramedics and 44 were students. So a little over 60, or a little about 60% were working paramedics. The others were students. The age, as you would imagine, the students were younger. They tended to be, in the 21, in the 20 to 22 age group, 21 years old. Whereas the paramedics, working paramedics, as we would imagine, would be older. Average age here, or median, was 42. Interestingly, I thought the gender was an interesting variable here. There are more, proportionally more female students in the students group, more female participants in the students group. So there's 60% or 59% female to male students, and in the practicing paramedics, it's kind of flipped. It's the 66% male to 34% female practicing paramedics. So I thought that was interesting. I don't know, Katie, if you noted that, or if you
I was a little jealous because there's no females in the class that I'm working with right now. I was like, how are they getting all these women to be students? What's their solution to the problem here?
Well, I'm wondering too, and what happens to their workforce afterwards? That's a totally different question, because this is not what we're looking at, but I thought that was very interesting. And then I wondered, is there something different, in decision making? Because that's what the study is looking for, is decision making. But As it turns out, there really isn't much of a difference. But and then the years of experience was the other participant characteristic they looked at. And I mentioned that before, 13 years is the median. They did end up splitting that into two groups. They could look at the, under 13 years and over 13 years in a later part of the study. And then the years of study, they actually broke down the students, which I think is actually important here too, because ultimately this is a computer test. It's not a patient in front of you, and we're looking at one piece. We're looking at just dispatch information, which in many ways, as I read this, I realized this really mimics a scenario-based critical thinking question on a test. So it got me thinking about all the stuff that's going on with ALS redesign and getting at, really trying to drive here in the US, the National Registry doing the ALS redesign, and what types of questions are going to be used in the new and revised test. And this really struck me as, is that what we're kind of getting at here, is, even though this is an Australian study, how to get at this idea of clinical decision making. So, but looking at the years of study is important too, because you would assume the more you're in school, the more you might be exposed to higher level questions, especially if you're in a program where you're studying clinical science. So, and you had about evenly split between the participants here, second year, third year, single degree, so that's your baccalaureate paramedic, and then fourth year combined degree, so you had another third of them in that group. So, that may actually play a role too as to why, the results, we see the results later on. So, I don't know, I just thought that was interesting. Did you, Katie, when you were reading this, did you think about did the ALS redesign, come up at all in your head?
Yeah, I thought it was interesting how they were like saying that they were making them do the click turn by turn, but they only did it for a certain amount of time, and it didn't actually matter if they got there or not. So I was thinking, I was like, oh, it's really interesting that you're trying to make them do something that's not actually related to answering the question to simulate like thought processes while you're on an ambulance, because everyone's, I'm thinking like cognitive load, but then my head went to, that's not really how it works in the field, right? Like the turn by turn directions, now we have GPS. So we're like maybe artificially trying to make a situation more difficult than it is in testing. And always just go back to the, like, you'll never have a multiple choice patient, but you're also not playing EMS alone. So just all these ways where we try to test people to see if they're ready to be in the field, just again, don't really seem to be mimicking the job environment well. So I don't know. That's what
exactly. And this is a small piece. So this is that, and I'm going to flip around for a second here. So I'm sorry to do this to people watching, but I thought here we go. I don't know. I must have zipped right by this slide, but the bottom line is what they want to know here. And these are the three research questions that came out of this. One is, what are the relationships between likelihood? Now, likelihood is that objective levels of likelihood in these acute coronary syndrome patients, which the person who's answering these questions, again, does not know that the idea behind this and the actual impression or the diagnosis is acute coronary syndrome for all those descriptions. So that's the objective likelihood and the subjective determination by the participant of how typical this is, the typicality. Answer fluency is how fast they answer the question. So answer fluency is, an interesting thing, but it's really the degree, to which they speak. It's measured, and this is a surrogate measure of answer fluency, would be the degree to which they answer this, in terms of how quickly do they answer that question. So it's measured again from the time they see it, the options, till the time they click the button. Really interesting stuff coming up here too. And then this self-reported confidence. Now, when I saw that too, this reminded me of a research study that we looked at before, and it also reminded me of I don't know if you've ever taken heart code. the American Heart Association heart codes, where you actually, and probably some other products have it too, where you go in and you have a question and you answer, or you gauge how confident you are on each question. And then a little person comes up sometimes and says, you know, an avatar comes up and says, you know, you've been underconfident on these, you're answering them right and you're answering low confidence, you might want to put some more confidence in yourself. You know, it's an interesting thing. But so they were doing sort of the same thing. They're saying, making the determination, determining how or how confident they were in their answer, and then saying how typical they thought the signs and symptoms were, the description of the patient as to what they chose. And then what the authors wanted to know is, what are the relationships between all those things? And then which of these study variables actually can predict what the paramedic impression would be? So the selection of paramedic impression. And then the final question here is, what's the relationship between the variables and paramedic experience? And that one's really interesting. So that's, you know, something we can take a look at. So again, this is just to, you know, look at this. This is the methods that they used, the choices that the students had, or the participants had, or paramedics and paramedic students, and how they went about this. So the first rounds were about practicing and getting them kind of used to what it was they were doing, and then they were going to be using different vignettes and answering those questions. So back to where we were, which was the breakdown of our participants. And again, this is in an experimental kind of lab setting, because we're just kind of starting this. This kind of launches a lot of questions and a lot of good plans for research. So the first thing that they find here is, and this is the first table that they show. So this is based on research question number 1. So, and remember, research question number 1 is, what's the relationship between all of these things? So what's the correlation? They found, as you can see, high, you know, or I'm not a statistician, so I don't look at this and say, well, you know, these numbers are what they are. I usually call Tony and Remley for that. But, you know, just looking at the, you know, of course, we look at the p-values and looking at what the authors, the way they describe it in, I really like the way they wrote this, actually. They break it down by the research question, their results right by the research question. So you can easily find what they found and what the interpretation is. So high correlation between the study variables, which isn't necessarily a surprise, right? So the faster you respond, you know, the more typical you think this is, and vice versa. The more confident you are, you might be faster to respond. The more confident I am, this is acute coronary syndrome, I might say, yeah, that's a typical presentation, and click, yeah, I have high confidence, and it looks like a typical presentation. So very high correlation between that and the likelihood, which was the objective point here. They also represented, they looked specifically at typicality or answer fluency and the time, and typicality, and how much again, this is subjective, so this is whether the typicality is subjective. This is the question that the participant clicked on that said, yes, I think that I select this, and you know, this condition, and we're looking again at, they actually split those up into dichotomous variables, acute coronary syndrome, and all of the other ones were just considered non-acute coronary syndrome. So typicality would be yeah, I thought it was typical of the acute coronary syndrome, and how fast they responded based upon what they determined as typical. So there's a couple of things in this here in this. This is a box plot with the little whiskers on the ends, and then the outliers of little dots up at the top. The pretty big spread in the middle too, which means there's kind of this area, you know, pretty big spread of timelines, and you notice the huge spread when it becomes atypical. And then the median is the dark line in the middle of the box. And you can see the pattern, even though there's overlapping, you know, when you see overlapping, it's a little less, you know, there might be some maybe you need a larger sample size to see more distinct differences, but there's definitely a trend that if it's very typical, for the most part, we had a really less variability and a very short time. Whereas if it's atypical, we had a lot of, maybe less indecision or more indecision and longer periods of times, lots of variability in there. Then in the middle, it looks like you got a lot of outliers. I'm wondering if the dots at the top are all the same person too. So what did you think, Katie?
Yeah, I mean, was reading this and I was like, I don't even like the answer choices. Like, I feel like I would have stopped because I'd be like, in my head, it's not a PE, he's got a GI problem for the guy with like burning, right? Or like it to me, it seemed like he was clearly ACS and it matched, or the other ones where it doesn't match any of the options you're giving me, which is why, like, so my, I guess it's like type 1 thinking, my gist or gut feeling, I can't find amongst the answer choices. So to me, that seemed like it would be what's impacting this here. So then you're like picking the wrong answer, but like the best of the wrong answers. So that it makes sense where it would take a longer time to do that. Not because it's atypical, but because he's like, well, I would have a different answer.
Yeah.
And one of the Greg has put in a comment here, question is that like the contextual difficulty is that what they're saying your diagnosis or impression is like based on more information than just the dispatch information. So is that making it really difficult to make these choices? I think that's a great kind of point there.
Yeah, for sure. And then the other point that I think it's Ulf Anderson makes a point that, or asks a question, do the paramedic students here have prior healthcare experience? So there's all kinds of other factors that might come into it as well. Not just healthcare experience, maybe experience in something where they have to make priority decisions really quickly. And also experience in again, critical thinking test taking. So it did make me think a lot about test taking, and we can talk about some of that as we get going here. But they did point out, though, in this study, that would be sort of another step to the study, which is looking at something in a setting of complexity. The impression isn't selected from dispatch information, but we do judge students on their impressions that they select when they take a test question, right? When they take a critical thinking test question, they get a vignette and they're asked, what is this? What do you suspect? and so they select one of those. So that's what I kept thinking. Wow, this reminds me of critical thinking test questions that we're, talking about. The difference is they add the distractor, they add the mapping, and they add that, time element. And the time element I thought was interesting, because what if, and I don't know if you've looked at this, Katie, or if anybody's looked at it, but has anybody done tests where you don't have just an overall timeline on a test? You have an hour and a half to finish this, 100-question test, but each item has a timeline. It's going to open up for X number of seconds, and you have that one, this much time to answer this question. This question will have this many seconds. Have you ever looked at that, or has anybody done that?
Yeah, actually, Heather Davis is on a call, and she has, or at least she knows this answer, and I only know because I like parrot everything that she taught me about education. But the longer that the students had with an item, actually, the worse that they performed.
Yeah.
You had to take in the fact of how much reading was in the question, but when she structured exams, we had to have like just a minute for the question unless there were more than 3 lines because of reading time, but specifically because that it does impact it, and it can impact it in a negative way if you give them too much time per question, which is really interesting. But they go back and they like change their answers and they second guess and they think about it. So it's
well also, and this reminds me of, this is going back, but we did a webinar on a study called why do students perform poorly on tests? That was truly one of my favorite studies of all time that we've looked at on this journal club. And it was it was residents, I think, and they really dissected. It reminded me a lot of this study because it was very specific. It was looking at something, it was really taking a deep dive and unpacking a very specific part of decision making. And what they were looking at, and they trained people, they had trained proctors on this. They looked at the decision making on a test. So it was very similar to this, but it was really looking at diagnosing the problem with test taking, especially for those who perform poorly. And it's just a terrific study. And it looked at, it broke it down where you would, look at a test question line by line, and at each step you would ask questions. What do you think it is, and what's your confidence level in that? It's sort of like this: how typical do you think this is based upon what you know? And then they, at the very end, they answer it and they find out. And they measured all these things, and they looked at differences in problems that students have. And it wasn't just sort of a generality that, I think generally you're right. And I think what Heather is saying, there's a lot of research on length of time, but I also think there's that one had some very specific things about, you can tell who is second guessing, who is, somebody who's bouncing between two answers, who's, where is there a cognitive deficit versus a test taking issue. So that kind of reminded me, a little bit of this, but I'm curious about whether or not, we should be looking at that kind of thing and getting at decision making. Is if we're trying to mimic that environment, then time should be an element. And having that, adding that 12 seconds of reading this and then making a decision, I thought was really interesting, and thought-provoking for other tests questions.
Yeah,
so.
Heather chimed in here that they're called speeded items. Best performance is 58 seconds. Less time, they didn't read all the choices, so maybe too much fast thinking, and too much time they changed their answer or second guessed themselves. So, yeah, I think you can see the type 1 versus type 2 thinking happening in this, the way that
and I'm wondering, Heather, too, and I don't know if, I'm not familiar with how to unmute you, and I'm not sure.
Oh, I can unmute her. I don't know if she wants to be unmuted.
Yeah. Well, Bill Toon is here, too. He's out there on the phone, and I don't know exactly how to unmute him. But, yeah, here's Heather.
Oh, I'm unmuted. I'm being quiet.
Yeah. Oh, you are? Okay. No, I'm just really curious about this, whether, because it's not just, every test taker isn't alike either. So it can't be just, there might be generalities if you look at a group, but each individual, not everybody's going to second guess. And that's what I think that one study of the medical students saw, is that individuals actually had different issues with test taking. They weren't all the same issue. So I'm curious about that.
And I think for me, one of the things that came up when I was looking at this was like, what's the bias if you're like gut choices, that they're having ACS or that they're not, and how recently we've been looking at studies of how changing protocols will drive people to do 12 leads or not do 12 leads, because you're like overcoming this gut decision of, I think it's ACS, I think it's not ACS, and to catch all those people. Also, that was interesting where, like, one of the things that I think Dave Page, he's not here to defend himself, but he always is talking about with item writing is like, you have to default to what's the most likely to kill them answer. And so when we're like thinking of like FISDAP right, wrong questions, that the answer is always going to be what's the most lethal. But specifically said here that that's not what people were doing. When asked, they weren't always picking the most lethal option. I don't know how you think like lethality of ACS versus PE, like how you judge that without knowing the size of the PE, but I thought that was really interesting.
Yeah, and they do mention it at some point. There's in the discussion, they talk about the hesitation, or what was it, the extremes of likelihood behaved as predicted, is what they said. But then right in the middle, those typical, neither typical or atypical, there's a lot of variability. And that's what it may have been, that they addressed that it may have been the description that they had, that, even though they based it on case studies and epidemiology and that kind of thing, it may not have been, but it also supported that there may be a degree of overdiagnosis that occurs in more ambiguous presentations, and I had a little note to myself that mimics testing environment also. You know, people will go with, you know, the most lethal rather than, you know, more accuracy. So yeah, that's what they mentioned that actually in the discussion area. So Bill, you're on. What did you, you know, looking at this plot, can you tell me if I'm correct in thinking, is there any concerns with the overlapping boxes here? Because I'm not a huge, you know, when I look at sort of the bottom half of the, you know, when you see them overlap like this, I kind of like to see them sort of spread out.
You know, I'm sure I am, but it would just demonstrate to you my lack of statistical understanding of things. So I'm a much more practical person.
Yeah.
So, but what I've liked about this is it's making me think, okay, how this is just very intriguing what they did. I actually just liked it from the perspective of what they did. What I'm interested in trying to do is how do we implement this into our educational process, or when do we end? What's the model that we could do if this is proven that you know, this method that they're evaluating here? So I'm actually interested in what's going to happen after this, what's coming next and stuff with this study work here.
Mm-hmm. Yeah, exactly. And they did say they were specifically looking at the impact of dispatch information. So as we're talking and saying, you know, you need more to come up with an impression, that's true, but they also cite some research that says the dispatch information has actually helped and also been a detriment if the impression, you know, if they get into their minds the impression too soon and have early closure and stay on that all the way through the call, even though we always say, you know, people say it all the time, well, the dispatch information, you can't listen to it, you know, use it to prepare, but be prepared for anything. How much of it is sort of an unconscious, you know, influence on inappropriate impressions or inaccurate impressions. So I thought that was it was intriguing, and the authors were really honest about the limitations and what they were specifically after, and they weren't after, you know, what's the paramedic's impression after they've encountered a patient. They're talking about specifically given the limited information of the dispatch and coming up with this impression. Now the next question would be, how much does that impact the next step? Oh, there's so many questions actually related to this.
I think one of the things that's like making a lot of noise, or people are talking about too, is the use of lights and sirens, and when then shouldn't go. And like, to me, this is a case here. I think there's a great argument that you should never use lights and sirens because it doesn't actually make a difference. But if we are going to do it and stratify it based on severity of the call, like what is, you know, are we actually able to do that? And are we over triaging everything? So then we're just going to end up like responding lights and sirens to everything anyway. Because
exactly, and over triage is, and you know, over triage is not always acceptable. You know, we keep hearing, well, you know, at least you err on the side of caution and, you know, take them, but it's also a resource question, right? So over triage is not necessarily what we want. We, you know, for everyone, it may not be the best for everyone. Especially given wall times and other things that people are dealing with and workforce shortages, and what does that all do to the patients? We've all been talking about what does it do to the workforce, but what is it doing to patient care? So yeah, I think that's a really good point. Okay, so let's move on a little bit, and then you can jump in. Keep those comments coming in. Thanks, Heather, for your comments. Heather's got a lot of experience when it comes to teaching and testing, and I like your comment about looking at the fast test takers. Oh yes, really want to prove the fast test takers are not the highest performers, but repeating those, you found out that they were highest performers. So, and it is probably likely a mix, like you said. Other things, test taking ability, confidence, all of those things. I agree. So
yeah, I tried for so long. I really wanted to prove that they were not the highest performers, that being a little bit careful and and just taking a moment to check your work, even on scene, right? That not falling into that trap of going with your first impression, and just making sure that you have situational awareness and taking time to hear the first responders report or gathering a little bit of information before you commit to a decision would be useful. But cohort after cohort after cohort, it turns out that the fastest were the highest performers. But we know a lot now about, test taking ability and reading ability. And also there is an efficacy piece there and trusting yourself. And so I do think it's important as educators to create an environment in which we get learners to be able to take a risk and know that it's a safe space in our simulations and in our classrooms to commit to their decision and to go with it. I think all of us who run scenarios and simulations have that moment where we're just wishing they would just make a decision. It's okay, and then let them see that through and learn from that too, and make that a safe place to do that, because unseen, the indecision is really what will create a problem as well. So all of those things, in the mix probably for what we were seeing, but years worth of data that proves that demonstrated that the fastest were indeed the highest scorers.
Yeah, and I'd love to bring back the studies, and I know Dave did some of them, and other people did, on neuroticism and and timing of tests and all of that kind of stuff, and look at that, and confidence, quote unquote, declared confidence, and that kind of thing.
So Heather, or just in general, that's an interesting point about their high performance as students. It would be interesting to see how it correlated to their field performance, though. That to me would be very interesting. Post graduation, did they continue to perform like that and make decisions and were considered good providers, compared to the person who was a little bit more methodical?
Yeah, and I think we're getting closer to having the opportunity to follow folks from student through new provider all the way through their career with the electronic record keeping and some of our systems that we just never had the opportunity to do before. So some of our big systems who take our students as interns and then are also our providers. I think there's going to be a moment in which we really can follow them from cradle through their career, if you will. So
yeah, I talked to Dave.
Important studies.
I've talked to Dave and Anthony about this, Tony about this idea that since ESO has become very popular, is schools that use FISDAP linking those students into the ESO database that also has patient outcome type stuff. And then, so the potential, I think we're on that cusp of it happening. There'll need to be still some more linkage that will take place, but I think that potential does exist, like you said. And I think that will really help us refine maybe or improve upon techniques that we are using to prepare people.
Yeah. Great points. Thanks for jumping in here. Appreciate it. So just moving on with the results of the study, this table here, and again, if you're not Remley or Dr. Fernandez, then you're like me and looking at this and saying, okay, this is going to take me a while to look at. But essentially what it is saying is this is getting at research question 2, which looks at the which of the study variables predict paramedic impression. And essentially what they're showing is all of these likelihood, typicality, answer fluency, and confidence all were related to the termination of the ACS versus non-ACS as the impression that the participant chose. Now, this is the one, this gets at research question 3, which wanted to look at the effective experience. And I'd love to get your input, and those out there in the chat and the question area, add your input on this. So what we're looking at here is all participants looking at the impression, proportional, selection of the impression, again, across the objective, most likely through least likely vignettes that we saw for acute coronary syndrome, all participants, then the students, then the experienced paramedics, and the more experienced paramedics. Less experienced paramedics meaning less than 13 years, and then more, and I don't know how 13 years was chosen. Maybe it just split them evenly. I can't remember if they actually said why they split it into 13 years and less. It might have been just like an even split between them, and looked at, you know, the proportion that's selected, the impression of acute coronary syndrome. So this is the, you know, essentially looking at accuracy based upon the likelihoods, different vignettes, and no real difference between the students and no impact of experience that they're seeing. So I don't know, was that surprising to anybody? And was there
just 13 years was the median amount of experience for the group? So they split it with like middle of experience, or more than the median or less than the median. Yeah. That makes sense. I don't know, for me, one of the things that I think that, like, as an instructor, I contend with preceptors sometimes is that things change in medicine and like we learn more. So, you know, the example that's always comes across is like sandbags for flail chest, like legitimately was somewhere in the curriculum at some point, but we know now that you shouldn't try to make it harder for people who are already having trouble breathing. Backboarding, like, should we use backboards? Should we not use backboards? Like, all that stuff changes. Oxygen, 15 liters on a breather versus not. And so I think sometimes you have more experience, but you spent so long doing the wrong thing. I don't know how many times I've paused and stopped and been like, is this the correct protocol, or is that 3 versions of the protocol again? I can't remember which version control I have in my head. So that, to me, it totally make why being more experienced is also means you're further away from school where you're being taught all of this stuff.
Yeah, or in testing environment, right?
Yeah.
Have you ever seen the situation where your experienced paramedics come back and you're putting them into a simulation, and they're like, oh, it like brings back, I'd rather run the real call, they always say, than run a simulation. They're like more stressed to run the simulation than the real call.
I mean, we have it here in LA because the scope of practice is so small here that when they come back for registry, they're like, oh, I've got to remember about steroids and other drugs. What? Why? Like, I just want to do albuterol for everyone who's got a slight difficult breathing. Like, just albuterol it all day. And I'm like, no, there's more drugs.
Yeah. So what about you, Bill? Or Heather, do you have any feedback on the kind of this table with the experience base, you know, no difference in the experience base? Other explanations for it, or do you think it's actually, maybe this isn't the time where experience matters?
Well, that's a good point. I was thinking, you know, what I was thinking is maybe the quality of the education program is so good, their initial education program, there's very little variance that takes place over experience. So they're really graduating competent individuals that maintain that competency over time. You would think, though, that your actual experience would influence, you know, your diagnostic or your decision making type stuff. So I was a little surprised by that. I want to dig into it a little bit more, but again, I'd like to see this model done in an actual clinical environment and not in this environment to see if there's more variable or whatever that comes into play. So it very fascinating. That's my take at it. Maybe it's just very good education.
Katie, how about simulation? And Heather, what do you think about, can this be mimicked in a simulation environment? We talk about a clinical environment. What about in simulation?
I just keep wondering about the testing effect. I'm wondering about the experienced paramedics and if they're waiting to be tricked. And there was some conversation in the article about risk aversion and whether or not they were sort of playing it safe or saying, okay, it could be ACS. I'm gonna, like, here, I just didn't think that here we have a situation where the paramedics have to decide whether they're going to write in or send it BLS. And I thought, there is no way they're writing in with all of those patients. So they put it on paper, but that is not what we would see clinically. And we could demonstrate that in terms of BLS transports versus ALS transports. So what this study showed is not what we would be able to demonstrate to you in patient care reports locally. So then I thought, I feel like there's a testing effect happening here where they know that there's a, they're being judged or they're being watched and sort of waiting for the other shoe to fall. So I do think that could be in play here. But the one other thing that I also was thinking about as I read the article was about tacit knowledge and when we think about decision making and how we teach our learners, that procedural knowledge of where you need to make a decision. And for our experienced paramedics, so much of that becomes automated and they're unconscious about it, and they're actually making decisions at so many points along the way that they would no longer be able to describe all the decisions that they have just automated. And certainly that happens for instructors as well. And so even the research shows that even when we think we have sort of written down very clear instructions, step by step, whether we've made a skill sheet or a task list or whatever, that we've really left out about 60% of the actual steps or the actual decision-making points. And so then we leave a lot of gaps for learners to fill in on their own. And so I kept thinking about that, like how many gaps have the inexperienced, are they filling in, and how much of the experienced paramedics are just doing this on their own automatically and not really thinking about it. So
I think that makes an argument too, Heather, for teaching early in your career. When we put these arbitrary determinations of how much experience you should have as a clinician before you teach, before you become a preceptor, before you become a teacher or whatever. And I think that that it raises the issue of if you're gone long enough from a teaching setting, or if you're out there experienced enough, you may, the longer you're gone, the more you may forget how to break down those individual tasks and what it was like to actually first learn. And then I guess it depends upon the importance of each step. So do we need to have these laundry list check sheets with steps in them that aren't as critical when we're in a field that requires, fast decision making and high priority, which steps are actually critical, that kind of thing. So
yeah, for sure we don't want super long checklists, but we do want to make sure that learners know that there was a decision that got made there. It's just that we didn't write it down, or we did that one in our head, because otherwise we leave these giant gaps where they're like, how did you get from point A to point B?
I think novice, right? Novice needs it. Yeah.
I think Leonardo makes this kind of point too, in a way of like, when we're experienced, we're educators, we think that like if you can categorize something as ACS, that means you must know that it's important that you leave fast, that you go to a semi-center. Like we're adding so much context to that, picking that multiple choice answer. I know when I see in simulation, we run the sims and the students like ask them like, what's your differential diagnosis? And they can't say ACS, but they're like, oh, he's having a problem with like oxygenation and blood flow. And I'm like, what does that mean? And they can't pick that answer. So Leonardo was like, I think you might have seen a difference if they had to do a short response versus picking a multiple choice. And I think that's a thing that we really don't look at enough, right? So we're giving them the multiple choice answers, and we're taking a lot of assumption on what that means that they know.
And the choices they gave did not include things like GERD when one of them had burning, in their stomach. Yeah. And so, yeah, I think I agree with that. If there was patients don't come with multiple choices, right? You got to figure it out from what you see. So I can't believe it's already been an hour, but we are at the top of the hour. So any final comments? The last table was actually just a frequency of the association between confidence and typicality, which was mentioned in another discussion earlier. So any other comments about this study? Anything you guys can see for the future before we close out?
Yeah, I just hope that we keep looking at stuff like this, and then we look at how it affects bias and patient outcome, right? So if we really think we're confident that we know the diagnosis, do we not do other things? Or does it make it better? Do we leave the trauma scene really quickly because we know that they're bleeding internally and they need a surgeon? So it could be both.
Yeah, great. All right, so please join us. We're going to close this out. Pre-Hospital Care Research Forum, Education Research Journal Club. Don't forget, there's a special edition live from AccreditCon on Friday, June 3rd at 12 noon Eastern time, so new time. And then we'll be back Friday, June 24th at 10 a.m. Pacific, noon Central. And the next PCRF Clinical Journal Club is Monday, June 13th. So we will see you next time. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.